ಏನಪ್ಪ
To all the doctors who've joined in, I would like to welcome you all to the Respinar Series 4, presented by IAP Respiratory Chapter. We're waiting for the others to join in, so request you to be a little patient. We'll be starting soon.
I'm here, Annie. Hello. Welcome, Dr. Vedantan. Welcome.
Welcome, Vedantan sir. Can you hear us? Vedantan sir, I'm Subramania here. Can you hear me?
Yeah.
Okay, thank you. At least you could log in.
But picture is not there. His picture is not here.
The computer start with. Okay.
Yeah, fine, sir. It's good now.
Okay, sir. Good morning.
Yeah, good morning.
Good morning there.
And happy Onam, sir.
Happy Onam.
Where's your meet? So, sir, now we can see about 85 attendees, so I think we can begin.
Yeah, fine. Let Dr. Vedantan settle a minute or so, then I will start. Let him check his audio, a couple of things.
Subbu, you can start off. In the meantime,
Vedantan sir, good morning for you and good evening for all the viewers. Can you hear us, sir?
Little bit of a starting trouble here.
No problem, sir. Sir, your audio, I think Himadri, please check his audio, no?
Yes, sir, I can see that his audio is connected. Sir, are you able to hear me?
Yeah, I can hear you.
Yeah, fine, sir.
Okay.
Thank you.
Okay.
So, good evening, viewers, and good morning, Vedantan sir. You are on the other part of the world, and what a time for us that we could, connect to you, and thanks to COVID. So that I want to just update you, sir, that Respinar has been one of the phases of the respiratory chapter in form of reaching out to pediatricians and bringing the respirology to their doorsteps. There have been successful Respinars, and this is the fourth Respinar. The first one was by Dr. Bush, and second one was I myself has to pitch in the meanwhile while we were arranging some more international faculty. The previous one was sleep by Dr. Omendra, and currently it's today we have Dr. Vedantan sir, professor of asthma and allergy, and he is from our part of the land, from Mysore, from my own state, and just hardly 100 kilometers away is his house from my house. So nice to have him. but he is dedicated to the field, and now he's there in US. He was the past president of World Asthma and Allergy um, organization, and then he has been a wonderful teacher to all of us. And there are many students of him across the country. Many of them have been trained in Vellore, Delhi, and in many places, either offline or online. And you have must have heard him in the past. This is just one or two lines about him from greetings from respiratory chapter, myself, and as well as from Dr. Jagdish Chinnappa. So let's hear from him. Before we would hear from him, I would just request Dr. Jagdish Chinnappa to open up Respinar 4 for us and wish the secretary and the team and the speaker all the best. We need a lot of blessings from our chairperson. Over to Dr. Jagdish Chinnappa.
Thank you, Dr. Subramania, for this wonderful evening where we have our respected past president of the respiratory chapter, Dr. Sukumaran from Kerala. We have today's organizing person, Professor Narayan Modi from Orissa. And I can only welcome Dr. Vedantan with one word. I know him from the last 20 to 25 years. And I've seen him in a much younger avatar, And I can tell you one thing, the man is passionate about allergy, not only passionate about allergy and practice of allergy, but in teaching allergy. And that is where his strength is. He is the mover and shaker of the two major allergy teaching programs in our country. And one of them is in the CMC Vellore, where he has set it up in a beautiful way. And many of the practicing allergy specialists today are all products of that program. The other one which he has recently started is at the Gangaram Hospital in Delhi. And I can tell you one thing, Dr. Vedantan is so passionate about teaching allergy, it is unbelievable. So I think we are going to have a wonderful evening from the man who has seen allergy grow in the last maybe 4 to 5 decades. So I think we will have a fantastic experiential talk on allergy. So I welcome you, sir, with the namaste and welcome back to India, though virtual.
Sir, thank you, Dr. Jagdish. Now we have got our past president of the respiratory chapter, Dr. Sukumaran, and our executive committee member, Dr. Modi. Since he is the coordinator, I welcome both of them. Dr. Sukumaran has been my guide and philosopher, and even has taught me pulmonology from being a pediatrician. So thank you very much, sir. It is nice to acknowledge your presence here. I will hand it over the sessions to Dr. Modi to coordinate, and later to Dr. Sukumaran as chairperson. Over to Dr. Modi.
Thank you, sir. Thank you so much. It's a great privilege to be in this Respinar platform, courtesy IAP National Respiratory Chapter, our president Chinnappa sir, and our general secretary, much loved Subbu bhai. I am blessed to get and connect with my teacher, my guide, philosopher, Professor P.K. Vedantan sir on this platform, and our Honorable Past President IAP Sukumaran sir, our chairperson. Now I have been given this dubious task of introducing my teacher, Professor Vedantan sir, in 2-3 minutes. I think it will be a crime if I try to just introduce PK sir in 2 minutes, because as Ramayana from a voluminous book by Tulsidas was converted into a single sloka, the whole Ramayana, that tough it is to describe and to introduce PK sir. He is a native from Mysore, India, and he completed his MBBS degree in 1969 from Mysore Medical College, did his post-graduation training in Brown University, Providence, Rhode Island, USA from 71 to 74 in medicine and pediatrics. He did his fellowship in allergy, asthma and immunology, Children Asthma Research Institute and Hospital, University of Colorado from 1974 to 76. In professional experience, he is a private consultant Allergy, Asthma and Immunology, Colorado, United States. He is a clinical professor, Department of Medicine, University of Colorado, since 1995 to this date. He is a chairman, founder of International Asthma Services, Colorado, United States, from 1992 till this date. He is a chairman, founder also of Vedanta Charities, which is registered in India, taking off a lot of service projects since 1997. He is a co-director of DAA program in CMC Vellore, Diploma in Allergy and Asthma, since 2006, and I am a blessed alumni of that program in 2007 to 2008, and I bloomed under his able and visionary leadership through asthma training under PK sir. He is a co-director also in DPAA program, which is being run by Dr. Neeraj, my friend, in Sar Gangaram Hospital and Research Center since 2019. He is a voluntary physician in a CAHEP program, CAHEP, in low-income child, Denver, Colorado. He is the lead editor in textbook of allergy for the clinician CRC player. His hobbies are Carnatic classical music, tabla, marching, hiking, swimming, yoga, walking, biking, travel, service projects, and motivational speaking, and whatnot. I think he is actually a lot many things we can never think of, molded into one personality, one persona. I welcome sir, and we all are grateful and privileged to have you in the Respinar 4 run by IAP National Respiratory Chapter. Now I hand over the mic to our ex-president, Professor T.U. Sukumaran sir, which is chairing the session, to say a brief word on this present Respinar. Thank you.
Okay. Beloved Jagadish, Subbu, Dr. Modi, and Dr. Vedantam, and my dear friends. It gives me great pleasure and privilege to be here with you to participate as chairperson of this fourth Respinar organized by the Respiratory Chapter of Indian Academy of Pediatrics. I should congratulate both Jagadish and Subbu, because they are taking the Respiratory Chapter to further heights. Since 2000, I was the chapter president. Now Jagadish and our friend Subbu has taken it over, and they have increased membership. At least we must increase the membership up to 2000. And I am very happy that throughout Kerala we are celebrating the Onam now. So it is a great pleasure to say happy Onam to all the participants and to all the audience, and also to Vedantam sir. I have great pleasure and privilege to be here with Dr. Vedantam, because I have got very sweet memories about him. And few years back, we were together in Sri Lanka for an allergy immunology conference. We were together, and he may be the, as Jagadish has said, he may be the top allergy specialist in the world now, and he's an excellent teacher and orator. According to WHO, said that there are mainly 8 top respiratory illness, including asthma, COPD, then chronic bronchitis, emphysema, lung cancer, cystic fibrosis, bronchiectasis, and pneumonia. In the absence of effective intervention, risk factors like smoking, air pollution, allergen exposure, severe childhood respiratory infections, and TB are expected to cause a further magnitude of this health problem in the coming years in the developing countries. Barrier to better global respiratory health includes generic barriers like poverty, poor education, lack of interaction, lack of sanitation, etc. And the environmental barriers include tobacco smoke, air pollution, and poor nutrition. And with this words, With great pleasure, I welcome Dr. Vedantam, and I request Dr. Vedantam to start his talk on respiratory barrier in normal versus diseased. Dr. Vedantam, please.
Thank you, Dr. Sukumaran. Can you hear me?
Yes, sir.
First of all, I want to thank the respiratory chapter of the Indian Academy of Pediatrics for making this possible, because we are all going through very difficult times with this pandemic all over the globe. To offer an educational feast like this to physicians who are busy otherwise, I think it's a great idea, and it will serve the purpose of continuing their educational maneuver. And I personally want to thank each one of you, because all of you I know for decades, as you just mentioned in the introduction. I know Dr. Subramaniam and his parents, Subramania, and we have a lot of fun talking to your parents, more fun talking to them than you. Because they talk about normal things. No, I was just, and Subramania has a great sense of humor, like we all know. Dr. Jagdish Chinnappa, I know for many years we have been doing several things together, and he's quite a personality in Karnataka as well as nationally, and I'm very happy to be associated with Dr. Jagdish. Dr. Sukumaran, I know for many, many years. We have met in several platforms. I think I do remember meeting you in Sri Lanka, where we discussed several things. And coming to Narayan Modi, I like his name very much. I like, we all are devotees of Narayana, and he has a very, very popular last name, And Narayan Modi was one of my favorite students because of two things. One, he was always curious and asked some very, I would say, tricky questions, always made you think. And he always had a smile at the same time, which made you more nervous. And, and actually, it has been a pleasure to know Dr. Narayan Modi and his whole family. He hosted us when we were in Cuttack a few years ago. As we are all aware, we are all clinicians. We are all 100% clinicians. We see patients from morning till evening. We think in a particular manner. We are concerned with the patient complaints. What can I do for that patient? What can I do for that particular disease the patient is having? But this topic is given to clinicians in a very different manner. We are going to talk about basics. We are going to talk about basic sciences applied clinically. So what I am trying to do here is trying to recollect our learnings from anatomy, physiology, pharmacology, pathology in the medical college. Go back to your histology labs, go back to your pathology lab. What did you learn there? What did you see there? And how can you apply that knowledge to the bedside? And that is what we will try to do. So this will be a little bit of an unusual experiment. And let me start. Let me go and share the screen. I hope it works okay. Because I had some trouble starting the other computer. So this is a very famous resort in New England, part of England, the United States in the northeastern portion, very, very scenic area. It is a very famous resort. Why am I showing this resort? Is people with allergies in about 100, 150 years ago, people who could afford, especially who are highly allergic to ragweed, which is a cousin of parthenium. Like we have a lot of parthenium in India. So these people would all escape into this resort from different parts of USA. These are people who are basically well-to-do. So what they were doing is avoidance therapy. If you're allergic to something, you just avoid the allergen and you'll be fine. So what they were, and since this is a very seasonal thing, they would come to this resort, stay for 2 months, have a good time, enjoy the mountains, no wheezing, sneezing, itching, no eye symptoms, and they go back. Very, very famous resort that is still existent in northeastern United States. And it's also a popular place where a very famous financial meeting occurred in 1944, where the United States dollar was considered as the world currency equal to the gold. You know, like that is where it started, that movement. Nothing to do with today's stock, but I just thought this was an interesting thing for us to share. Now, I'm going to talk a little bit about a case scenario, and I'll come to that later. A scenario is a 1-year-old Kumar with a history of moderate atopic dermatitis was referred to our office due to concern with food allergy. This child was a product of C-section, 39 weeks gestation, weighed 7 pounds 10 ounces at birth, exclusively breastfed, 1 year of age, was given breast milk and developed acute urticaria, vomiting, respiratory distress, the first consumption of cow's milk. Medical history, infantile eczema since 4 months of age, poorly controlled. Family history strongly positive for atopy, both sides. When they did skin testing on milk, it was strongly positive. They eliminated the milk and milk products. Eczema care improved. 2 years of age, eczema had improved. And that winter, he was admitted in respiratory distress with wheezing due to viral infection. 3rd year, he had nasal symptoms, eye symptoms. And now the diagnosis is persistent asthma, allergic rhinitis, inhalant sensitization. And when they did the skin testing for milk around 4th year of age, it was much smaller. The milk allergy was gone by itself. It was introduced milk and he was able to tolerate. So this is a typical atopic march. So people with atopic dermatitis are at risk 6 times more develop food allergy, and 60% of severe atopic dermatitis patients develop asthma, but not every patient. And rhinitis asthma, there is a significant correlation, 75% correlation. And a Th2 response to one allergen, if you are sensitized to one allergen like a dust mite, it potentiates a similar response to others. So this is a case of typical allergic march. The risk factors here were the strong family history and acculturation. That is, this is a kid who was born to Indian parents, brought up in a different environment in the United States. So there is a cultural environmental influence. So this is a typical example of gene environment interaction. And as we all know, that food allergy, atopic dermatitis, family history are all risk factors for asthma. How did he get sensitized to milk? He had always had breast milk. How did the child get sensitized to dust mites? Was it an anaphylactic reaction to milk? What is the natural course of cow's milk allergy? These answers will be answered as we go through. But the child got sensitized to milk through the skin, not by drinking. He had already got transmission of the antigen through the skin. So it is the skin sensitization to the milk that caused him had milk allergy to start with. And dust mite sensitivity, as he got older, the dust mite sensitivity through the respiratory tract. And did he have an anaphylactic reaction to milk? Yes, he had 2 systems involved. He had both respiratory and dermal systems involved. Natural course of milk allergy, as they get older, they get better. 80% get better by the age of 5 years. So this is how sensitization occurs through the skin due to filaggrin deficiency. Why am I showing this when I'm talking about respiratory barrier? Is in pediatrics, respiratory problems are preceded by dermal problems. And also there is significant data to show that usage of broad spectrum antibiotic in the 1st year of age which alters the microbiota of the alimentary tract, has an influence on respiratory microbiota. So respiratory problems in young children may have a dermal route to start with, may have an intestinal route to start with. So this is the typical allergic conditions that we know of, where you start off with eczema, then the eczema gets better, asthma starts, and then the allergic rhinitis starts. I mean, actually, after eczema, the food allergy starts. As the food allergies are waning off, the asthma starts, then the allergic rhinitis starts. So these are some of the terminologies that we'll be using. What is atopy? Atopy is a genetic state. We use this word a lot. We say this child is atopic. That means he has a genetic wiring. Sensitization is an immunological state. That means he's sensitized to dust mite, he's sensitized to cockroach, but allergy is a clinical state. Allergy is when you are having symptoms. I am exposed to the dust mite antigen and I'm having symptoms. When I am having sneezing, wheezing, that is a clinical state. Neosensitization is developing of newer sensitization. Gene environment interactions is when you're genetically wired, genetically prone, like that child, and had an environmental interaction where the exposure to the dust mite or the exposure to the milk antigen is there. There's a close interaction, and that causes the disease to show up. Epigenetics is another word that people use very much. Epigenetics is a change in the gene expression where there is no actual difference in the primary DNA sequence, but the gene expression changes. And that can happen due to things that we take it for granted. That is, tobacco smoke exposure can do that. Diesel fumes can do that. That means heavy pollution, heavy polluted areas can cause epigenetic changes. Dust mite can do it. The problem with the epigenetics is once epigenetics has happened, it can get transmitted through generations. And the good thing about epigenetics, it can be reversed with environmental control with treatment. Now, when you are going through these type of changes, there are certain things that occur at the epithelial level, which we are going to discuss a little later, where there are certain extracellular junctional components that are compromised. Because allergy, you need to know the basic defect in allergy, it is not IgE. It is not IgE. The basic defect is an epithelial defect. Asthma is an epithelial disease. Allergic rhinitis is an epithelial disease. Asthma is a T cell driven disease. So the basic changes happen at the epithelium, and that is the genetic defect. I showed you one slide where I showed you that flagellin deficiency of flagellin atopic dermatitis. It occurs at the epithelial level. So respiratory tract. What is the respiratory? We have two, upper and lower. The external, if you look at the nose, you have this external nose which looks very attractive. Most of the people look at somebody's nose and say, hey, you have a nice looking nose and all that, but very few people look inside the nose. For us clinicians, we are interested in the external nose to some extent, but we are more interested in the internal nose. If you look at the nose internally, the nose extends several centimeters behind, almost like 1.5 to 2 inches. And you have all these different turbinates that are like shutter-like mechanisms. Nose is a difficult place to examine. When you look in the nose, you can only see 20% of the nose. So to examine the nose properly, you actually need a rhinoscopic examination. So why am I showing the nose? Because nose, if you ask anybody what is the function of the nose, the first thing they will say is to smell. But actually, the function of the nose is to prepare the air for the lungs. It humidifies the air, it filters the air, it warms the air, it slows down the air. So when you are breathing in the air could be at any outside, depending on the outside temperature. It could be very cold, it could be warm. It could be polluted, it could have dust, it could have pollens. And the first thing the nose does, vibrise they call it, at the entrance of the nose you have that hair and all that. That is where there are what they call as chemoreceptors. This is very essential to function as a virtual valve. There is no valve that you'll see, but there are these thermoreceptors, sorry, they sense the temperature, and they either dilate or they constrict. So they regulate the amount of air that goes into the lungs, into the nose, and also it reduces the velocity of the nose, the airflow. It has been estimated that when you take air into the nose, it can go anywhere between around 20 to 30 miles an hour. It is so fast it is going. But the vibrise or the vestibule, that area, I'm sorry, vibrise is the hair, vestibule, that area due to constriction can bring down the velocity of the air to a few meters a second. So once the air is slowed, then your nose has a chance to humidify the air, to filter the air, to warm the air, and as well as clean up the air. So by the time the air reaches your throat, it is filtered, it is 100% humidified, and it is clean, as well as it is slowed down. So within a matter of 2 inches, the nose is able to do this much every time you breathe in, because this is the way the air has to enter the lungs. Suppose you are not able to breathe through the nose because of some pathology in the nose, and you are breathing through the mouth, you are going to lose all these advantages. The air which is polluted, the air which is whatever is at the ambient temperature, if it is cold, it enters the lungs and it gives you bronchospasm. If it is polluted and full of dust, it can exacerbate the existing inflammation. So that is the problem with the mouth breathing. So it's always very essential for us to promote nasal breathing. If you look at the lower respiratory tract does 2 things. One, conduction of the air. Another is gas exchange. The air is prepared by the nose, enters the lungs through the trachea. It comes through the trachea, going through the bronchi, bronchioles, and once it reaches the alveoli, oxygen is taken in, carbon dioxide is out, and that is what happens in the lower respiratory tract. So lungs are major organs of respiration. We use only about 20% of the nose of the lungs when we are doing our regular activities. So we have a lot of reserve power. Say like you climb up the stairs or you have to run and get something, your reserve capacity comes through. And the reserve capacity is what makes it go for you to do certain functions that you need to do right away. But that is lost in conditions like COPD, where there's a damage of the lungs. Now, if you look at the real world situation, nose is highly cosmetic. Medically, it's ignored. Most of us don't look at the nose inside. Rarely examined, difficult to examine. Functions are not appreciated because people do not know what the nose is doing. And if there is a nasal congestion, it is ignored and ignored by the medical profession also. Sneezing and running nose is taken for granted. So many times allergic rhinitis is not at all taken seriously and is basically given some decongestants, antihistamines. Whereas in the lungs, which is not even visible, we take things very seriously. We always examine the lungs, we x-ray the lungs, it's easy to examine, functions are given a lot of value, hard to diagnose, and coughing and wheezing are always worrisome, both to the patient and to the doctor. They always run to the physician when they were having chest symptoms, but they don't come to the doctor when they're having upper airway symptoms until it interferes with their lifestyle. So the reality is nose does a lot more than we realize. It does a lot of functions, as I just mentioned to you in the last few slides. So the summary slide is nose prepares the air for the lungs. The lungs will conduct and exchange the gases, but it is very important for us to realize that upper and lower airways are always one. Whatever happens in the upper airway will affect the lower airway, both in normal physiological state as well as in pathological states. When you have an allergic nose, there is a significant damage to the respiratory epithelium. So normal mucous membrane will show good ciliated glands, intact epithelium. With allergies, there is a loss of epithelial integrity, loss of cilia, intense eosinophilic infiltration, thickening of the basement membrane, and hypertrophied mucous glands. These are the things that happen. How it happens, I will tell you later. And this will tell you what is an allergic mechanism. Basically, there are two phases in allergic mechanism. One is called sensitization, another is re-exposure. In sensitization, the antigen is taken up by the antigen presenting cell. How is that antigen entering the respiratory tract or the skin? Is because you have a compromised epithelial integrity. There is some defect in the epithelium of the skin or in the respiratory tract or in the GI tract in allergic individuals. And that genetic defect will weaken the barrier between the cells, and that allows the allergen to enter through those roots, and the antigen presenting cell picks up the antigen, presents to the T cell, which is genetically a Th2 driven T cell, which tells the B cell, I don't want to see this antigen again. I don't like this person. I want you to produce IgE antibodies. So the IgE antibodies are produced, which circulates freely in the serum, but also it goes and hooks on to the mast cells and basophils on certain receptors. So the mast cell, which has got the IgE on the surface of it, which is specific IgE against particular antigen, is called armed mast cell. So now the patient is sensitized. So the next exposure to that particular antigen, the same allergen enters through the compromised epithelium. The IgE is sitting right there on the surface of the mast cell. Two IgE molecules will couple with each other. That means two identical IgE molecules against the same allergen will hold on to the allergen, and that causes degranulation of the mast cell. Mediators are released, the main mediator being histamine, and there are several tryptase, kinase, and also the delayed ones like prostaglandins as well as leukotrienes are formed and released there. So that causes the intense allergic inflammation. Early allergic inflammation causes redness, swelling, itching, and that is why people have sneezing, rhinorrhea, and itching when they have allergic rhinitis. But they are also stuffy all the time. That is because of the late phase reaction where there is cellular infiltration and significant inflammation. So clinically speaking, both for asthma and allergies, it is the late phase that we treat all the time. It is the late phase that causes the disease. It is the late phase that causes the remodeling of the airways. And that is what we are treating with intranasal steroids and inhaled steroids. And that actually does very, very good to reduce some of this inflammation and actually restore the epithelial integrity structural wise, but not genetically. The defect is still there. Structurally, it may get better when you use inhaled steroid, but the genetic defect will not disappear. So these are the united airway concept, where these upper airway diseases and lower airway diseases coexist with each other. They influence each other. And this is important for you to know that what happens in the upper airways will also influence the lower airways. And these are all different diseases that can do it. It is not allergic rhinitis, asthma, but it can also be rhinosinusitis, bronchiectasis, COPD, cystic fibrosis. All these conditions which are not allergic also can be influenced by the pathology in the upper airways, influencing the lower airways. So summary slide, allergic nose is an inflamed nose. Inflamed nose doesn't function well. This leads to lower airway inflammation. So never ignore an inflamed nose. So if you look at the respiratory, now coming to the respiratory epithelium, there are many types of cells. You have we all know that there is ciliated epithelial cells. The cilia is there. Then you have airway basal cells. You have club cells. You have mucus secreting goblet cells. These are the common types of epithelial cells in the mucous membrane. The most important cell here is not the epithelial cell, not the ciliated cell. It is the basal cell. Basal cell works like a stem cell here, just like it is like a bone marrow for our hemopoietic system. Basal cell is the stem cell. All these cells I just mentioned to you are originating from the basal cell. So basal membrane is a very crucial part of the human airway epithelium, because the basal cells is what makes the mucus secreting cells to form later. Then you have certain special cells called neuroendocrine cells, ionocytes, chemosensory cells, like that. Now, if you look at each of these cells, ciliated epithelial cells, it is very, very important for proper functioning of the mucous membrane. So cilia does a lot. So there is mucociliary action, which we will talk a few minutes later. So the cilia makes a huge difference. Now, depending upon the dynamics of the airflow, when I say dynamics, initially I mentioned to you, when air enters the nose, the air is entering at a high speed. It is at variable temperature. It could be cold, it could be hot, it could be polluted. So you need something like a strong epithelium there at the entrance of the nose. You need something strong. Ciliary epithelium is not a strong epithelium. So ciliated epithelium is not a strong epithelium. It is the squamous epithelium. Stratified squamous epithelium is as strong as the skin. So at the initial portion of the nose, where at the junction, if you look at the nose, as you put, when you look in the nose, the skin continues into the mucous membrane. The mucous membrane looks a little shiny. In that area, you have what we call as stratified squamous epithelium. Stratified squamous epithelium is a strong epithelium, and it can withstand the high speed, it can withstand the varying temperature, it can withstand the pollutants. And once the air flow is slowed down, then the epithelium changes. From squamous epithelium, it becomes ciliated epithelium. So what I'm trying to say is the epithelial character depends upon the dynamics of the airflow. So the faster the airflow, the more polluted the airflow, you have squamous epithelium. The slower the airflow, where you need more things to be done to the air by humidification, warming of the air, filtering of the air, and that can happen only when the air is slowed down. You need ciliated epithelium. And then you also have these goblet cells I just showed you. These are the goblet cells. Looks like a little flask here. And the main function of the goblet cells is to produce mucus. There are two types of mucus. One is the outer layer, is called the gel layer, and an underlying layer is a sol layer. Gel layer is thick. It has got the main constituent of the gel layer is mucin. it is 97% water, 2% mucin, and another a little bit constituents of other things. But the function of the gel layer or the outermost layer is to entrap these particles that you're breathing in. You have to imagine it is like an escalator. It is like a mucus escalator, mucociliary escalator. It is moving because of the ciliary movement. It is moving. As it is moving, the outer mucus layer, which is thick and sticky, will catch these particles, the dust particles, the dust mite particles, the whatever smoke and all these particles that we talk about are caught in the thick mucus layer. Right underlying that is the sol layer, which is the aqueous layer, which is helps the cilia to move. So what the cilia does, it keeps on moving in one direction, that is to the direction towards the posterior part of the pharynx. So all these pollutants, the impurities in the air, are gradually coming up. They have even measured how fast it goes. I think it goes like every 20 minutes it moves like a centimeter, so it's quite fast. And the cilia move several hundreds of times a minute to and as this escalator carries all these particles to the back of the throat, that is when you swallow. Yeah, all of us have this swallowing reflex. Very important. We take it for granted. During this talk, you probably will swallow 8 to 10 times, maybe more. Every time you swallow, what it means is the mucociliary junction has carried, the mucociliary action has taken all these particles through the back of the throat, and you have swallowed it, it goes into your stomach. So what happens in underneath, like below the larynx, what is happening in the trachea? You still have ciliated epithelium there. There also, the cilia will work in the opposite direction. It is going against the gravity. The same mucus is there. The goblet cells are there. And this escalator is working in the opposite direction in the trachea, bringing all those impurities again to the back of the throat, and you swallow it again. And that is how it works. In the nose, it goes backwards. In the trachea and the bronchi, it moves upwards. And it is all brought to the posterior pharynx where you swallow and goes into your stomach. Very, very important. The reason why this is important is when the patient is anesthetized, or there are certain drugs that can sort of interfere with the swallowing reflex. If you are not able to swallow, then all the secretions sort of gobble up and they start flowing. That is why you do the suctioning. You do manual suctioning when the patient is anesthetized, or even under local anesthesia where you have anesthetized this reflex, you have to do suctioning because it is not working. And another important thing is this ciliary function. Ciliary function is also messed up or interfered by allergies, by inflammation, by infection, environmental tobacco smoke. So when you have this issue, not uncommon for people to keep on clearing their throat like that. They keep on doing it, they cough, because the secretions are not mobilized properly. It is not like they have a pathology in the posterior throat. It is the mucociliary transport which is compromised in these conditions, and that causes the postnasal drip, and that is a poor part and parcel of the upper airway disease. So it's very, very important for us to think about this mucociliary function in these diseases. Now, I also felt in this slide, I did not know I had forgotten to make a note that when they did this work, then they found there are certain receptors called taste receptors. Taste receptors are also found in these mucous membranes, and taste receptors have something to do with the epithelial function. say, and they also found there are two types of taste receptors. One taste receptor for a bitter taste, another one for a sweet taste. So the taste receptor for the bitterness seems to stimulate the epithelial function, which means that some of the older ways that we have been treating for ages, like neem tree extracts, and many things, we keep on saying, oh, this medicine doesn't taste good at all, I don't like it. Oh, but it is good for you. So probably these bitter tasting medications are stimulating the mucociliary function through those taste receptors, whereas the sweetness actually dampens the mucociliary function. So this is a very interesting concept. More work is being done on the relationship of the taste receptors on the mucociliary function, and this is applicable to some of the things that we do in daily medicine. Okay, sorry. Now, if you look at the respiratory epithelial barrier is like a wall. It is separating your tissues from the environment. Environment is a harsh environment. We are living in a harsh environment. There are because the temperature is different. Temperature could vary from hour to hour. What is the content of the air depends upon where you live, how close you are to traffic junctions, and not everyone has got access to clean mountain air, So we are having highly polluted areas where people, unfortunately, the density of the population is very high. But does it mean that these people who are living there are breathing very, very bad air all the time? Probably not. There are people who are quite healthy in those areas too, but depends upon how good their epithelial functions are. Okay. People who are compromised, they definitely are sicker in these environments. It has been also shown that the prevalence and the intensity of allergic diseases, including asthma, rhinitis, and several other upper airway diseases and lower airway diseases, are much more intense in high traffic zones because of these pollutants. And these pollutants can cause a damage to compromised epithelium, not for everybody. Say, for example, if you are inhaling dust mite antigen, or inhaling pollens from the air, all these antigens have what we call as protease activity. They have proteins in them. It is the proteins that are allergic, and these proteins have a protease activity. So what the protease in these allergens do is they work on these epithelial junctions and damages it, and so that the epithelium becomes compromised. So it actually facilitates the entry of the antigens through the respiratory tract, through the damage caused by these proteases. We do not know why it does not damage normal people without any atopic background, who do not have any disease. Their epithelium is not damaged by these proteases, but people who are genetically prone to develop allergic diseases, who have got a compromised epithelial defect due to genes, are very prone to this damage by these antigens that has got this protease activity. So this physical barrier is very important. Physical barrier of the epithelium, you need to know, it's a tough barrier. One of the toughest tissues in our body is the skin. Several layers you have, but it protects you against very harsh environment. And although the respiratory tract mucous membrane is only very, very thin, it is still a very tough membrane in normal people. Then you have what we call as immunological barriers. These cells have the capacity to produce certain uh, microbial, antimicrobial substances, including immunoglobulin A also. So they are able to produce substances that can interfere with bacteria, with viruses. So normal mucous membrane can cause immunological barriers to the invading organisms. Then we talked about mucociliary clearance. Then you have cytokines and chemokines. These cells also have the capacity to produce cytokines and chemokines, produce inflammation, and as well as they are all a part of the innate immunity. They are able to protect you against these against these pathogenic substances. So what exactly happens at the epithelial level is epithelial cells have, like any other cell, they have what they call as PRR, pattern recognition receptors. And pattern recognition receptors are on the cells of the epithelial cells. The antigens have pathogen associated molecular patterns. These are genetic material. These are, so just for example, how do I recognize you are Dr. Jagdish Chinnappa? Is somebody will bring you and say, he is Dr. Jagdish. Oh yeah, you look like you are Dr. Jagdish Chinnappa. Please come in, have a seat. Somebody walks in and says, I am Jagdish Chinnappa. I don't know you. So this receptor will recognize, is this a foreign substance? Is this something I should let you in? Is it something I can accept you? So this is where the recognition of the microbe occurs, recognition of anything foreign. So the pattern recognition receptors and the pathogen associated molecule pattern interact with each other, and that is the first signal to the body that somebody has come in. Somebody rings your doorbell and you open the door and you recognize the person, you know who the person is, you let him in. Same way, the immune system is given a signal when somebody enters your respiratory tract or dermal or elementary, an outsider comes in, and then a message is sent. If the message shows that this is a foreign antigen, then the pattern recognition receptor will say, this is not you, this is not somebody I am going to accept. I am going to form some cytokines, chemokines, and antimicrobials against you, and I don't want to let you in. So it activates the innate immune system right there. It is right in the cell. It activates the immune cells, which is in the epithelial tract. There, these cells, the dendritic cells, which is a part of the epithelium, is activated right away. And these cells start producing these cytokines and chemokines locally right there, and tries to limit the entry of the foreigner, of the antigen. And when the cytokines and the chemokines are produced locally, and that is when you have inflammation. The membrane swells up. When there is inflammation, which is good for you, so that you are limiting the infiltration, but in one way it is also bad for you because it damages the respiratory tract. Now, the more the inflammation, more the damage, there is more repair. And this causes what we call as airway remodeling. So this inflammation, this response, the cytokine response, antimicrobial response, this war is going on 24/7, and that causes inflammation. Inflammation of the mucous membrane causes wound, and then the healing starts at the same time. And this wound healing, this cycle is what causes airway remodeling. So when that happens, it will look like the Indian roads. When you travel in some of the Indian roads, you will see the da 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 da, the car goes, and that is remodeling. When you are going in this nice airway, nice highway across around Bangalore, that is the normal mucous membrane. Smooth, nice, pink, that is straight. And that is the way it should be. But it is not like that other ways, because it is damaged, it's repaired, damaged, repaired, and that causes the airway remodeling. So what it is telling you is everything is happening at the epithelial level. Epithelial level is where the culprit is sitting. Epithelial level, that is where the pathology is. And epithelial level is where you need to concentrate your treatment. Now, at the epithelial level, it is not just the epithelial cells that are causing it. It is also being taught how to handle it by the immunological cells, the main immunological cell which does the monitoring and commanding is the T cell. So asthma is a T cell driven disease. Allergy is a T cell driven disease. Asthma is an epithelial cell disease. So you need to remember that you need to target not bronchospasm, you have to target the epithelium, not IgE, but the T cell. So total IgE is an indirect measure. It is not going to do anything for us. So when you target treatment, target the T cell, target the epithelium. And so when you target the epithelium, good news is you can repair, you can actually reverse many of these damages. So luckily for us, inhaled steroids restores the epithelium, restores the epithelial integrity. And that is the biggest advantage of inhaled steroids. It's not antihistamines, it's not bronchodilators. So why are we so successful with inhaled steroids? Is it restores the epithelial integrity. But will it stop the damage? No, because the damage is being done in these allergic individuals by the T cell. So you need to target the T cell. How do you target the T cell? By allergen immunotherapy, not antihistamines, not anti-leukotrienes. None of the medications will work on the T cell. So the combination of inhaled steroids, allergen immunotherapy, environmental control will help the T cell to function better and for the mucous membranes to regain their integrity. And that is how this knowledge can be applied clinically. So epithelial cell wall has a major role in the innate immune functions. This is all a part of the innate immune system. And the inflammatory mediators have been, and the other thing is the inflammatory mediators seem to promote the allergic response. Say like I told you that there will be cytokines, chemokines that are formed at the entry of these foreign antigen. But when that happens, it seems to favor the Th2. So it makes the allergic phenomena become stronger and stronger. Another thing which is also very interesting is virals. It's a viral infection. Say like it is a child with the one I presented to you with that atopic background and gets a viral infection. The viral infection causes the epithelial cell damage. And the same cytokines and chemokines are released. Due to the viral infection, due to the inflammation, these mediators are released. Actually, those mediators will promote an allergic response. So that is why you see that viral infections and allergic manifestations go hand in hand in these patients. Children with allergies, if you take the history, they seem to get a lot more viral infection. And people who have had viral infection seem to get more allergic manifestations. And that is where the omalizumab seems to help very much. It cuts down the seasonal flare-up of the viral infections, and because it also has cut down on the seasonal flare-up of allergies. So they seem to go hand in hand. So then you have all these microbiota, very, very important. It is very essential for life, for protection and prevention of killing of bacteria. And we talked about the physical barrier, and I briefly mentioned about the taste receptors because I did not know this slide was a little bit away here. Then you also have other antimicrobial proteins, beta defensin, surfactant proteins, innate. These are all present in the epithelial cell. So a lot of things are occurring at the epithelial cell to limit the infection and to build up an immunological response. So if you look at the microscopy, how is this happening? How is this integrity of the mucous membrane is being maintained is because of certain junctions or certain portions of that epithelial cell. If you look at this is diagrammatic. So there is a area called tight junction. These are all different proteins that are involved. Tight junction is at the apex of the epithelial cell. The tight junction sort of covers up the apex and gives a firm impermeable membrane there. It makes it impermeable at the apex. Below that, there is a thing called adherence junction where it brings the two cells together and makes the two cells adhere to each other. And desmosome is another area which does the same thing. And there is a hemidesmosome which anchors the epithelial cell to the basement membrane. So what it shows is how well it is architecturally engineered. Every cell is held on to the basement membrane. Every cell is hooked on to each other. Overall, the epithelial cells are wrapped up, held tightly together. So this is an engineering feat which is occurring in billions of cells without any major thing. Unless you really look for it, you really will not appreciate the amount of the architectural excellence in the human body at the cellular level. This is absolutely great. And the way it is done, these are junctional components, and they know what are all the different types of protein involvement are there at each level. In the tight junctions, you have occludins, claudins, and there is a JAM1, which is called junctional adhesion molecules. And they have done quite a bit of work here. And we know what happens to these junctions when the conditions are not friendly. For example, as I mentioned to you earlier, say like you are genetically prone and you are exposed to those pollutants, diesel exhaust fumes, pollens. What it does, it damages the TJs, it damages the AJs, and damages the desmosome. And that is how the epithelial integrity is lost. Sorry. Oh, I'm sorry. These are the intercellular junctions. It is the same sort of a slide showing you a little more detail how a columnar cell is looking, and the goblet cell and the airway basal cell. Airway basal cell, although looks smaller, it is like a stem cell, very, very important cell. So the basement membrane integrity is very, very crucial for us. Through that airway basal cell, all these cells are formed. It works like a stem cell. It is like a bone marrow. And if you look at the human airway epithelium, and this is the ciliated epithelium, and then you have the goblet cells here. Then this is a close-up, and this is the ciliary gel I talked about, how it works. And this is how the cilia works. This is not very, very good. It has not come out well here. And if you look at the amount of mucus that we produce every day, it's almost like an ounce, that we have that much of mucus that we are swallowing. And if you are not able to, if you have a diseased mucous membrane like you have in conditions with allergic rhinitis or chronic rhinosinusitis or COPD and asthma, when you're producing this mucus, depending on the type of mucus, you are also having more symptoms. And this is to just show you the airway mucus is produced by these mucus secreting goblet cells, which is very, very important in having the epithelial barrier. Now, these are two types of mucins, mucin 5AC, mucin 5B. This has to do, you don't have to remember all that. It is the ratio between the gel and sol, which is important. There are conditions where the thick mucus, the gel, is produced more than the sol. And there are conditions where the gel is reduced compared to the sol. So we all know in asthma, the mucus is thick, hard to bring up. Very rare for an asthmatic to cough up mucus freely. Whereas a COPD patient or a chronic bronchitis is able to produce a lot of mucus. He produces sputum because the way there is an imbalance between the gel and the sol layers in these patients. The asthmatic produces more there is a lot of goblet cell hyperplasia. He produces this thick mucus, which is hard to bring up. So when there's an imbalance between the gel and the sol, when there's a lot of gel, that gets heavy, and the sol, the aqueous layer, gets narrower, the cilia is not able to move very well. The cilia can only move in the sol area. So the mucus escalator is interfered with. So there is mucus accumulation, and that makes the patients a lot more symptomatic. So when you give inhaled steroids, reduces the inflammation, reduces the gel formation, and gets the balance together, the epithelial integrity is resumed. Whereas in chronic bronchitis, you have more sol than gel. You have a lot more aqueous things. So there is a lot more mucus that is produced in these patients. So this ratio between gel and sol makes a huge difference in these diseases. So it's important to treat the epithelium in these diseases very much. So if you look at, this is the physical barrier. This is showing you the natural physical barrier of the upper airways. I have already mentioned to you about these different cells, the epithelial cells, goblet cell, basal cell, basement membrane. These are the four things you need to remember: ciliary epithelial cell, goblet cells, basal cell, the basement membrane. Under the outside the epithelium, you have the gel layer and the periciliary layer. That means that is the aqueous layer. It is very, very interesting that this cilia never comes in contact with any of these pollutants. It does not come in contact with pollens or any of these particles because it is all trapped in the mucus, and the cilia is free to move and get the escalator moving towards the posterior pharynx. So there is no direct connection in a normal acting epithelium between the pollutant and the epithelial cell. There is no direct contact in a normal person. Suppose it is a deceased person, then this is what happens. If it is airway epithelial cell, these are the things in susceptible people like cigarette smoke, air pollutants, respiratory virus, and protease allergens. They will produce protease and damage the junction. They damage the junction, they damage the TJ, they damage the AJ, and they damage the desmosome. They are able to penetrate between the cells. They are able to penetrate between the cells. Because they're damaging, the cilia doesn't work, and the mucus, the blanket is gone, and that is airway barrier is disrupted by inflammation, hence anti-inflammatory agents are effective. So anyway, this is the damaged mucous membrane. So the protective things that helps the epithelium to regain its nature is glucocorticoids, budesonide, fluticasone, and beta 2 adrenergic receptor agonist, and there are other things. So, but basically inhaled steroids seems to help us in this situation. Now there is one slide I missed here. There is a cell called innate lymphoid cells, ILC, which is actually is a newly discovered cell, which is a part of the innate Th2 cytokine produced. So it does not need a antigen presenting cell. It doesn't need any T cell. This is an independent lymphoid cell which is already able to produce chemokines, cytokines. It's able to produce interleukin 5, interleukin 13. By itself, it can cause eosinophil reflux. It can cause local allergic inflammation against inhaled allergen. So innate lymphoid cells are also activated in human allergic diseases. So summary slide is normal airway is a very, very tight, efficient, and very, very smooth. And that is attained by these tight junctions, adherent junction, and desmosomes. Desmosomes are those joining things between the cells. And mucus, as I mentioned to you, plays a huge role. Ciliary function is very crucial. But when you have a compromised airway where the mucus is too much or too little, or when the edges are damaged due to protease activity, or due to viral infection, or due to environmental tobacco smoke, or due to any other noxious agents, then the airways becomes leaky, it becomes inflamed, it becomes dysfunctional, and that itself will produce more cytokines. And this damage is present in allergic rhinitis, asthma, COPD, and fortunately, this damage is responsive to our treatment. So this is just showing you enzymes of the allergen that can affect the epithelial barrier. I know I don't know how much time I have left, but this slide is sort of summarizing several pollens, major mite antigens, molds that can do this. And in this happens, important point, this happens in genetically susceptible persons. This does not happen in normal people. Normal epithelium damage to the junctional areas due to pollens will not occur. This occurs in people who are genetically prone, and that is why gene environmental interactions happens. The same thing is shown here, like multiple agents can affect the epithelial damage. That includes chemicals and allergens, pathogens, pollutants, causing the facilitation of the allergic sensitization. One thing that happens is when you have a damage, what happens is it facilitates more allergens to enter. So once the damage is done, more allergens enter, more cytokines, more inflammation, more damage, and more tissue remodeling. And that leads to chronicity. These are all environmental factors that can compromise the epithelial barrier. As you see, it is protease allergens, detergents, cigarettes, ozone, particulate matter, and microplastics, nanoparticles. So it can happen, a lot of things can happen, and a lot of different chemicals can happen, can cause this damage. These are all the different phenotypes of rhinitis and rhinosinusitis, and phenotypes and endotypes. Because of lack of time, I can't go through all this. And can we fix this? Yes, we can actually. I told you microbiota is compromised in these patients. So Lactococcus lactis is which can actually can help the microbiota situation. The inhaled steroids can definitely restore the barrier function. And there are studies to tell you that dupilumab, anti-IL-5, anti-IL-4, anti-IgE also reduces the Th2 inflammation and tries to bring the adaptive immune response back to normal. So that means we have good news here. So our treatment is working. So that is the message here. We know what is the damage. If you catch the damage early enough and treat, it is definitely much more beneficial than to let it go and try to catch it much later on. Okay, so this is the good news. Epithelial integrity can be restored. Intranasal as well as inhaled steroids are effective. Biologicals are effective. Anti-inflammatory therapy will help. Antimicrobials is effective. So coming to this case, child was very highly atopic. Inhalant allergies set in as the food allergies got better. He has what we call as a progressive allergic disease. So that means he has one allergy will set in another allergy. As he gets older, food allergy got better, inhalant allergy got worse. So what can you do is to slow down and or stop the allergic march, and the management education, environmental measures, pharmacotherapy as we just discussed, immunotherapy to target the T cell. So I think by combination of this approach, you can slow down the process. You can actually, once you teach the T cell how to behave, you probably can help the situation so well that inhaled steroid dosage can be reduced or even eliminated in some of these patients. So is there a cure? I don't think there's a complete cure, but we actually can do a real good job getting things under control. Let me stop here. I may have talked a little too much or too fast. Excuse me,
Yeah.
but I am open to any discussion or questions. Thank you very much for your patient hearing.
Thank you, sir, for an excellent talk on the physiology of allergic disorders and also highlighting the importance of epithelial cells and also Th2 cells in the production of allergic disorders in children. Sir, I have got two questions now. What is the role of probiotics, immunomodulators, and vitamin D?
Probiotics, and what is the next one?
Probiotics, immunomodulators, and vitamin D. Vitamin D.
Now, let's talk about probiotics. Now, we know microbiota, if you look at it, there are certain general statements which are very true. More bacteria, more variety, more diversity, better it is. A diverse microbiota is much more effective than a monobacteria. If you have one type of bacteria, it doesn't work. But if you have a mixture of bacteria which seem to get along well, that seems to work very well. With the problem with the probiotic is you're trying to push one type of bacteria. So it will not be as effective as what a normal microbiota does. And studies have shown that probiotics seems to help the eczema patients, the onset of eczema or the progression, but not allergic rhinitis or asthma or any of these conditions yet. So probiotics are not very useful yet in asthmatics or people with established allergies, but in eczema people, it seems to be of some benefit. Now, as far as vitamin C and immunomodulator will not work at the level where we are talking, where the T cells are involved. And it has not been shown that it seems to influence the T cell activity on the B cell. So it is not very, very effective as far as we know in these conditions. But it seems to help certain autoimmune type of problems where the immunological mechanisms could be different. It probably can slow it down or something. But in allergy conditions where there's an overactivity of these T cells, and the interaction between T and B cells, it has not been shown to be that effective. Vitamin C, I'm not very sure.
Vitamin D,
Probably
vitamin D
could be helpful in integrity, but I don't know.
Yes, Subbu will take a few questions.
Yeah, sir, I will take up the questions from the audience.
Yeah.
I'm Dr. Subramania here, but what I wanted to tell you before I take up the questions is there have been more claps and applauds than questions. So for wonderful lucid talk from you. So there has been a lot of compliments more than the questions, but I will take up some of the questions.
Thank you.
Why those already sensitized do not always respond by allergic reaction by re-exposure? What he meant was why on re-exposure the mechanism is different, but for first sensitize, see why the second sensitization mechanism is not similar to the first one. That is a question.
Let me come to that first part of the question. Now, when you say sensitization, it's an immunological state. Say like I take 100 people and I skin test them. I will find 40 of them will be sensitized to, even 60 of them will be sensitized to a major antigen like dust mite. Then I go back and ask the history. How many people are having symptoms consistent with dust mite allergy, like early morning sneezing, wheezing, and that type of stuff? Only 12 to 15% will have it. So what that means is you can have sensitization, but you don't have to have allergy. So sensitization is an immunological status. Allergy is a clinical status. But when does immunological state become a clinical state is the question. So they did a very interesting study at Brown University where I went. There were two allergists, Dr. Sati Payne and another one, Dr. Brown. They did a very interesting study where in the university you have captive population. You have students coming in every day. They stay with you for several years. So they skin tested these patients and found a significant number of them were sensitized to a particular allergen. And they followed them for the next 28 years. After they graduated, they're working and they're like almost 45, 50-year-old, they were still following them. They found that patients who were sensitized but no symptoms, the risk of developing allergy is 10 times more compared to who are not sensitized. So you are sensitized, you can develop symptoms later on as you get older, depending upon several factors, environmental factors. Are you a smoker? What type of lifestyle you have? Are you living in a very densely populated area? And so many factors are there. Are you having animal pets inside the house? And all sorts of cockroach exposure, this exposure. So all these things is a matter of time. So what is important here, if you are sensitized, treat them when they are sensitized. That is what I am trying to say. How do you treat? Treat them with environmental control, not medications. He is not having symptoms. Treat them with environmental controls, because I showed you in the histology, in the slides, that when you are sensitized, that means damage has occurred. Epithelial damage has occurred. The epithelium is compromised already. You may not have symptoms, but the IgE mechanism has started. The antigen antibody reaction has started. The T cell has become activated and it is promoting the Th2 pathway to get very active. And the more sensitization, more IgE production, and there is a threshold when the symptoms starts coming. So when you are sensitized, treat them with environmental control and follow them every year, so that earlier you catch, the better you can treat.
Okay, thank you, sir. The next question is, somebody is having actually the disease and he has asked the question. He doesn't have any anatomical abnormality of the nose. His nose is anatomically normal, but he has some symptoms on exposure to cold air. He's asking the question, is cold air just the physics or neural, or does the cold air behaves like an allergen? I think I have actually oversimplified the question of a complicated paragraph that has been written. So his
No, no.
question is cold air an allergen or is it just a neural stimulus?
No, I think it's a good question. What it means is, first of all, he is not imagining. It is true. Cold air will cause symptoms. What is the mechanism? Mechanism is the same cells, mast cells, are also prone to degranulate due to non-IgE mechanisms. Physical factors can also influence these mast cells as well as basophils. So cold air, physical activity, and these type of factors can influence the same cytokine release and cause symptoms. Okay. So
Okay.
the mast cells can release these mediators due to non-IgE mechanisms also. These are what we can come under physical factors.
Okay.
But breathing cold air through the nose, if he is breathing properly through the nose, chances are the nose is able to actually increase the temperature, does a much better job than he's breathing through the mouth. If he's breathing through the mouth, the cold air directly enters the lungs and causes bronchospasm. We know that already.
Okay. So the next question is why eosinophils or IgE do not grow in all allergic patients. I think I'll simplify the question. Why you have some getting IgE and eosinophilic response and why some do not get it? What is the actual mechanism?
Now, actual mechanism of allergy mechanism is you need to go back to the T cell, the B cell. Okay. The T cell is telling the B cell produce IgE, IgE gets hooked onto the mast cell, then you got the re-exposure, then I told you that mechanism. Now, when you have inflammation, these cytokines, they draw in, they get these eosinophils to the site of the allergic inflammation, because eosinophils are powerful, very, very powerful cells. Okay, they not only cause a significant inflammation, but also they clean up. They are also very good scavengers. So eosinophils are there for a particular reason, but eosinophils is a non-specific type of cell. It does not come only with allergies. Any type of this type of inflammation, the eosinophils are drawn. Parasitic infestation, and there are so many drugs that can cause eosinophil to be drawn to the inflamed area, but doesn't mean it's IgE. It doesn't mean an allergy. So eosinophilic infiltration is non-specific, but it is truly an indicator of inflammation. And whereas IgE also can be non-specific. That means you can produce IgE due to non-specific stimulation like parasitic stimulation, and due to some what we call as carbohydrate component. There are people who are total IgE can be very high, but they don't have any allergies. So IgE is not an indicator of allergy, but IgE is an indicator of overactivity of the immune system. So there is a particular difference. IgE is not an indicator of allergy, but IgE is an indicator of overactive. Your immune system is overactive due to some irritant or some stimulation, but doesn't mean it's allergy. So if you want to say it's allergy, you have to demonstrate specific IgE against a particular antigen. Say, for example, in atopic dermatitis, IgE could be 5,000. Why is it so? Is it all allergy? Probably not, because the atopic skin is leaky. It is a lot of different substances are getting into the skin, through the skin, and they produce non-specific rise of IgE. Doesn't mean it is all allergy. So it is sort of a fine drawing that we have. There's a lot of confusion here, but we have to be aware that
just a corollary to the same question what I used to teach my students, let me tell you, sir, is that eosinophil is a frustrated leukocyte. It cannot behave like a neutrophil, therefore it vomits out all the mediators. It's a frustration. maybe. Anyway, fine. I think I will go to the next.
That is a good way to put it. But the recent evidence, I forgot to put it in the slide. Actually, I had made another presentation. I got stuck in the other computer, actually. I got stuck in the other computer. And eosinophil actually now is shown to work almost like a neutrophil now. It is similar to the neutrophil. It's anti-inflammatory. It is actually seems to be doing more work than what we thought. So it is almost bringing on, we are finding that eosinophil is working more like a neutrophil. I'll send you some articles on that.
Okay, sir. So the next question is the obesity. We have the fat below the skin. Is there something in obesity below the respiratory epithelium as well? This is just a skewed question.
What is obesity?
No, apart from being a pro-inflammatory state.
Yeah, that is exactly, you gave the answer already. There is nothing like anything like a fat there under the respiratory membrane. But obesity, as you know, the same cytokines, chemokines, or interleukins are produced. Obesity is an inflammatory condition, like you mentioned, and that probably can influence the same. It is a different mechanism, but it is nothing like a fat under the epithelium.
Okay, fine. Sir, I quickly go to question from Dr. Neha Agarwal. She's asking viral infection induced inflammation like V's associated lower respiratory tract infection occurs in genetically susceptible as well as genetically non-susceptible individuals. Why it is that the only few develop asthma and not all genetically susceptible develop asthma? I want you to answer this question taking off environment.
Taking off environment. Okay.
Yeah.
It is like it depends upon the virus. First of all, when we say virus, it's a general term. We don't know what type of virus. If you take a common cold, respiratory virus, and if you take a common cold virus is 10 times more asthmogenic compared to an RSV. So RSV can cause damage, but it won't cause that much asthma compared to a common cold. So it depends upon the virus that is affecting the person. Until we know what type of virus, it's very difficult to comment on it. And it does not mean that every viral infection will cause the same damage, because it depends upon the characteristic of the virus and the interaction there.
Yeah, Dr. Raj Tilak has asked the basis of allergic march, but I will redefine the question for you. That is it because the surface area of the membranes are different? Is it related to the timing of exposure? Why that specific march is the question.
There are some people who don't believe in this allergic march. Allergic march is a very convenient term. One leads to another to another. It is the progression. So there are people where we don't see this march. They are definitely atopic. They develop eczema, then they get better, and then for a few years they have a asthma. Doesn't mean it is classical allergic march. But allergic march, it only shows the progression of the disease, not for everyone. So you can have significant skipping of the allergic march and still be quite atopic. And so the exact mechanism why it actually happens may not be that much clear yet.
Okay, sir. The next question.
Controversial subject.
Yeah. Next question is on yoga. And they have asked about your comments, but I'm making a question for you very clearly. Does yoga help by improving breathing and, the kind of capacities and volumes, or does it have some role at cellular level?
Yoga, we thought initially when we did the studies in the 80s, this is a long time ago, it seemed to help in two different ways. But the major way it helped was more in the psychological aspect. That means these people were much calmer. They were able to handle the asthma flare-ups much better. Their tendency to use inhalers right away was much less. So they use less inhalers, the yoga group, compared to the non-yoga group, because they were able to manage it with certain breathing exercises by remaining calmer. And as you know, the airway reactivity can get less as you are breathing in certain types of breathing techniques. But whether it is causing at the cellular level, there has been some recent studies that does not seem to support that it is causing any type of cytokine release or interleukin levels or anything like that. Okay, so I think yoga seems to be more of a as like on, if you are already treating the allergy asthma in a particular way, it won't replace all the medicines, but as a complementary measure, it makes a good thing. And another major important thing I forgot to mention to you is a lot of these patients with chronic disease do not feel good. They have a negative self-image. Yoga undoes that. Most of the people with yoga had a positive image, and they felt a lot better. They felt good about themselves, and that itself helped the course of this disease. So I think it's a good complementary thing.
Sir, for want of time, I will take one or two questions more. One, Dr. Shetanshu Srivastav has asked a question. Worm infestation in children, has it got any protective role? I think that comes to hygiene hypothesis, sir.
Yeah.
Hygiene hypothesis.
Which worm infestation you mean?
Worm infestation, does it protect?
I'm sitting in front of you. I was infested with all the worms that you can think of. Okay. When we were growing up, we had tons of Ascaris lumbricoids. This doesn't mean I can prove it definitely protected, but it has probably, because you produce so much of IgE. What IgE does, it takes up all those spaces and doesn't allow the specific IgE to, even if I form specific IgE, there is no receptor that is free to cause these symptoms. So definitely it seems to be a protective role in these diseases.
Okay, the next question is, perhaps I would sum up that how does the stress causes asthma? Stress.
Oh, stress.
Yeah.
That's a very important thing. Stress, it was shown that the study that I remember is stress during the last trimester of pregnancy. If the mother is highly stressed out, the chances of that child that is being born developing asthma is much higher than to a non-stressed person. So when you have stress, you produce the same interleukins. It is same inflammatory mediators that are also produced, and that probably might have also compromised some of the immunological functions. It is transmitted to the child and has been shown to have a deleterious effect in the development of asthma in these patients. So it is not a bad idea to go back to our old method. When the mother is pregnant, send her back to where she is more comfortable, that is her mother's home, than to go on
Keeping her
struggling.
in that. Yeah, right. Yeah. Sir, the question is that stress releases cortisol, and according to the questioner, Dr. Bansal, it should help. But the point is that the stress produces more of cholinergic imbalance, and that's the mechanism perhaps.
No, it actually produces interleukins.
Interleukins. So fine. I think there are questions, sir. Last question I will take with your permission, because it's already 10:40 here. Do you see any rhinoviral vaccine probably coming in? This is a difficult, not related to this thing, but okay, let me put the question in a different way. Can you see an asthma vaccine coming?
Asthma vaccine?
Yeah.
We do have a vaccine for syncytial virus, but we do not have a vaccine for regular common cold. If it does, it definitely will help.
It will help.
Definitely.
Definitely it will help.
Yes, because it has been shown I forget the name of the preparation, the vaccine for the respiratory syndrome, that seems to have shown a definite improvement the way the viruses are handled. So,
So
but we do not,
lastly,
unfortunately, for the
yeah,
rest.
lastly, one question. Does this steam inhalations, do they help in this your gel sol theory? Steam inhalation?
What theory? The
Steam
gel.
inhalation, gel sol theory that you told. The liquid layer, aqueous layer, tough layer. Does the
It
steam
probably,
inhalation helps?
if you look at logically, it probably should. You know, even say for example, saltwater irrigation, nasal irrigation has been shown to be effective. But question is, when is it effective? If you just spray a few squirts in the nose, we think it works because it seems to be a little bit more comfortable, but it has been shown, but that is not so. So if the saline irrigation works best at low pressure, high volume, that is when you do the Jalaneti or the other technique where you are putting more than 100 cc's in a slow pressure, that seems to be more effective.
Yeah.
So saline irrigation, also we need to be concerned where it is not sodium, it is chloride. There are other elements that probably has some role in it, like magnesium and all that has a role. And it has been shown that seawater composition seems to work best. So just a comment there, never use tap water for irrigation because it has been shown to have some meningococcal diseases have happened, infections. So it is better to use sterile distilled water or something you get it out of the pharmacy. Steam inhalation is not going to cause any adverse effects unless if it is, some people cannot handle it, they start coughing. Okay.
Okay.
Then you can.
Sir, last question plus comment from me. Till date, many pediatricians and many physicians have been understanding asthma as an disease of chronic inflammation, progressive inflammation. But nicely, you have brought it out. It is not the inflammation, but it is a mucosal disease.
It's a mucosal disease. It is.
I think you can just give your final comments that it is more a mucosal disease. It's more an epithelial disease than an inflammation.
Yeah,
And inflammation is only effect of it.
Yes, that is the most important message of this talk is please think about epithelium, okay, and please think about the T cell because those go together, and treat the epithelium early enough than treating bronchospasm and treating the cough and treating other symptoms. How do you treat the epithelium we already talked about? Is the easiest way is inhale steroids, intranasal steroids, and that seems to be the one armamentarium we have. And if you find atopic sensitization is there, then treat the allergy by environmental control and immunotherapy if possible. And that is the best way to handle these patients. But one warning is not all asthma is the same. This is applicable for allergic asthma. There are non-allergic asthmas also, which comes in adult onset. But in pediatrics, 80% of these patients have allergies as the cause of their asthma.
Sir, thank you very much. It was in fact an academic feast, treat, and I would say Onam party to all of us in one line. It was an Onam party. I don't think we could have had any better Onam celebration than just listening to you with that such nice, wonderful slides, and I would say an extraordinary explanation. And I think it opened the eyes of many of us. I think all in the panel, all in the question box, many of them themselves are benefited apart from their patients. And I think this is a very insightful lecture. I think there will be a lot of demands for the recorded sessions, or with your permission, we will disseminate the knowledge to everyone. I will just ask Dr. Sukumaran sir and Modi to finally say yes to me, and Jagdish Chinappa, if you could permit me can we close the session, or if any of you have any remarks to make, I would allow, and lastly I would come in.
I think the prerogative of the last word lies with Professor Sukumaran.
Okay,
Because he is,
thank you very
he is,
much.
he is, he is, he is our champion of the respiratory chapter, and who has nurtured the respiratory chapter. So I think the last word should be from Professor Sukumaran.
Okay, fine.
Dear,
Jagdish, you have got any
dear
quick
friends,
line?
it's a wonderful session. I once again thank the Dr. Vedanandam for an excellent presentation. And also, I think we have changed our concepts regarding the pathogenesis of asthma and allergic disorders after
Thank you.
hearing your talk. Thank you very much, sir.
Thank you. Happy Onam.
Okay.
Good night, sir. Good
Namaskara,
night.
sir.
Good
Namaskara.
night. Good night. Good night.
Thank you.
Thank you, Mark. Thank you, ClearNet.